It's a procedure that has a lot less side effects than the TURP, and achieves similar results. There is no cutting like there would be with a TURP. It's the laser energy that vaporizes the tissue in real time. We actually see the defect as we're operating, and it's done as an outpatient, meaning you don't have to spend the night in the hospital. Most people are able to return to normal activities pretty quickly, although they do have a lot of irritative symptoms, meaning frequency and urgency while the inflammation is resolving. We're going to show you a video of the laser TURP, just so you kind of get a sense for what we're really doing. Sometimes a picture's worth 1,000 words. One thing to talk about these things, another thing to really kind of see them. I think we need you, Rebecca.
Gotcha.
Okay, so now we're looking down the barrel into the prostate. That light that you see is laser energy that's coming through a quartz fiber, and you can see that yellow tissue. That is coagulated tissue deep to the tissue that's vaporized. The bubbles are actually the carbon dioxide, the carbon in the tissue turning into CO2, the vapor. And yet, in real time, you can see as that laser is moving back and forth and emitting energy that the black space is opening up. We're creating that defect, that opening where the obstruction, where the tissue is coming together. So you can kind of see how this laser procedure works to vaporize the tissue and create a nice wide caliber channel for the urine to go through. The laser energy is really neat because not only does it vaporize the tissue, but the tissue that's deep to the tissue that gets vaporized is coagulated, so there's no bleeding. You don't see any blood. It's essentially a bloodless procedure, unlike the TURP, where you're going to need to be in the hospital and irrigated for several days while you're waiting for the bleeding to subside after the procedure. So again, we're moving the scope around, and all the tissue that's in the lumen and obstructing the flow is being addressed by the urologist here who's moving the laser fiber around. That's Dr. Boschko.
And then the difference is with the laser, you can see it's vaporizing. When we do a TURP, if you can imagine, it's a U-shaped wire. So instead of going on the surface to vaporize the tissue, you go like underneath it and you scoop it out. And that's why we call the TURP the roto-rooter, because you're going in and literally scraping out the tissue. And so it's the most effective out of all these because you're actually physically getting rid of chunks of tissue, but it certainly is the most invasive, as Dr. Blair mentioned. This is coming towards the end of the video, so you can see, if you remember how the first part looked, the tissue on the sides were closing on the channel, and here you got a nice wide open lumen.
All that opening, all that black is where tissue used to be is now open. Okay, so a couple of common questions that people often ask us is, what about insurance? These procedures sound good, but does insurance cover these treatments? Well, definitely some of the older procedures, the TURP and the laser TURP, we don't normally have problems with patients' insurances getting them pre-certified and covering them. The UroLift and the Resume, not always covered, but as time goes by, most insurers are now covering those. It's a case-by-case basis. We take you through a process, if this is an appropriate procedure for you, to do that pre-certification. Are you eligible for either treatment? Well, there's reasons that, these treatments may be good for you. Some of these reasons include people who are unhappy with their medicines. Some people don't like taking medicine every day. Medicine has side effects. Over time, as the prostate gets bigger, the medicine stops working. I like to say that when the problem is mild to moderate, medicine can be a good solution. But as time goes by and the problem becomes more moderate to severe, medicine just doesn't cut the mustard. You really need a more effective procedure to open the channel up. So sometimes that medicine just loses its efficacy, and you really need to think about doing something a little bit more effective. Some people, when they're diagnosed with prostate enlargement, already have a big problem, and they don't want to waste time with medicine. They want to go right to a more definitive solution. These are all people who might, be leaning towards doing one of these procedures. How much experience? We've been doing all these procedures for a long time. We were really probably in the area, the people that were doing the most laser surgery. Of late, we've been replacing our laser surgery volume with some of the Resume and UroLift because we find that these newer procedures are able to give very close, similar efficacy and benefits to the laser procedures without some of that morbidity. So why shouldn't everybody get one of these treatments? Again, our goal is that you understand your disease process, we understand your anatomy, your physiology, we understand what matters to you. Once we take all those things into consideration, we're gonna make a shared decision-making process to figure out what's the best treatment for you and tailor the treatment to your particular situation. Sometimes one of these treatments is the way to go, sometimes following it, sometimes medicines, sometimes two medicines, sometimes minimally invasive, sometimes, you know, the TURP and the laser TURP, it all depends on the situation. We're gonna open the floor for general questions about prostate cancer, prostatitis, prostate enlargement, anything prostate related. At the end, we'll also make time for any personal questions that patients may have. After the group leaves, we can talk to people on a one-on-one basis about their particular situation. So we wanna thank you all for coming. We know it's driving through the cold and coming in here on a Thursday night. We appreciate you guys coming, and we're happy to address any questions anybody has. So I'll do this side and I'll let Dr. Bosch, we'll go back and forth. How can we help you?
What role, if any, would the consumption of any amount of water have on what was discussed here this evening?
Well, I mean, the more water you drink, the more urine you're gonna make. So people that have a problem with an enlarged prostate, in general, we like to tell you to drink a lot of water because it's healthy for your kidneys. But when you're kind of barely getting by because your reserve capacity is diminished by drinking a lot, by the bladder being overworked to get the urine through a narrow channel, sometimes that can unmask a problem. And sometimes people will be told to drink a lot of water and they're getting by, and suddenly they'll go into urinary retention because it's kind of like you're loading up the camel's back and then that final straw breaks the camel's back. So we often see people that are doing well and maybe they, you know, they have a whole gallon of iced tea, and then they can't urinate. They end up in the emergency room. We're asked to come put a catheter in. So drinking a lot of water is helpful, but when you have a problem with an enlarged prostate, sometimes it's hard to drink as much as people tell you to drink. I don't know, am I answering your question?
Yes, sir.
I haven't seen a urologist in 35 years, so my question is, when do you switch from the internist monitoring this to going directly to the urologist?
So, I mean, if you trust your internist for mild symptoms usually feel comfortable following you until they feel that you personally are not doing well enough in the medicine. So you go to your internist and explain to them that your symptoms are worsening, they're deteriorating, or if they notice certain other factors, maybe your kidneys not working as well when they do your annual blood work, maybe you present and say, with a urinary infection. Urinary infections are almost pathognomonic for men who have enlarged prostates who are not being well treated. So that's usually what the internist will say, you know what, you should probably see a urologist.
I guess I could make that decision on my own, couldn't I?
Sure.
Do you ever do a cystoscopy to see the condition of the inside of the prostate? What's the diagnostic?
Repeat the question, please.
Yeah, he asked, do we ever do a cystoscopy to look at the prostate anatomy? Right, am I getting your question right? And the answer is yes, absolutely. We don't want to do a cystoscopy on everybody because it kind of hurts. And there's also a very small risk of infection. So,
What cause you to do it?
what would cause me to do it? So a lot of times which procedure we choose, if you go back, Dr. Bosch goes way ahead of me, you go back to this picture, let's say you have severe symptoms and you got the flow of someone who looks like they're about to go in urinary retention, it's barely coming out, you're peeing like that Morse code that we talked about. You're gonna need something done in all likelihood. The question is, what do we do? Well, looking with the scope, with the cystoscope, can tell us, hey, this guy's not gonna do well on alpha blockers. He's gonna fail. He needs a bigger deal. So the anatomy dictates which procedures are gonna be effective and how effective. And so that's a decision that we would make after talking to you and doing less invasive studies. I can't give you a general rule, everybody gets a cysto, nobody gets a cysto. It's on a case-by-case basis.
Will an ultrasound give you this picture?
I'm sorry, sir?
Will an ultrasound give you these pictures?
Well, so I would say an ultrasound is complementary in some ways to a cystoscopy, but if you want the best lower urinary tract study, the best way to assess lower urinary tract anatomy, by far, is cystoscopy. You can get some information from an ultrasound, but you can't get as much information as you can from a cystoscopy.
Just to follow up on those two questions. So cystoscopy is also done on the initial intake. What Dr. Blair was talking about is that we have to rule out other diseases, whether it's scar tissue or bladder stones or bladder cancer or a variety of other issues. So if someone presents with irritated urinary issues and they might have some microscopic blood in the urine, you would do a cystoscopy without a question to rule out some of those other diseases. And in terms of your question about ultrasound, so ultrasound could do a decent job at showing this median lobe. About 15% of men have a median lobe, but it does not show you the inside of the prostate where the urine goes. So it doesn't show you anything whatsoever about the degree of obstruction. It might tell you prostate size, but size does not correlate with obstruction.
On the Eurolift, which lasts 5 or 7 years, what happens after that? Is it redone? Can other procedures be done, like surgery after that? What happens after 5 years?
So all of these minimally invasive, whether it's the Eurolift or the Resume, none of them preclude the ability to do the more invasive therapies, whether it's laser or whether it's the TURP. Okay, so sometimes these procedures don't even work. Let's say you discuss with a person and say, you know what, you really think more for your degree of obstruction, you should have a laser TURP or a TURP. Okay, but a person gets to decide for themselves what they want to do. They say, you know what, let me try the less invasive. So you try the less invasive. Let's say it doesn't work to the extent that you want. It's not a guarantee that it's going to work, because again, depending on the degree of obstruction. And it's not just obstruction, it's also the bladder. The bladder is a very important organ when we're looking at the prostate overall. So if it doesn't work as well as it intends to, you could always, 3 months later, 6 months later, whatever it might be, say, you know what, didn't do what we want, let's go ahead and go do something else.
And any of these or all of these procedures, aside from opening up and permitting a proper flow of urine, how about the urgency of needing to go a couple of times, 2-3 times at night? Does it do anything for that?
So that's where the bladder comes in. Okay, so if you imagine, again, you have your bladder, the bladder has to push to get the urine to come out through the prostate. We've got some of these other pictures that we had that shows you how the bladder builds up muscle. Over here, on the right side of the screen, you see all these, looks like licorice, or I don't know how everybody describes it, nice tree branches. So that's the bladder really pushing to get the urine to come out, and that changes the elasticity of the bladder. The longer you allow the prostate to go untreated, the more the bladder gets affected. The more the bladder gets affected, the less it's simply, okay, let's treat the prostate and everything gets better. Because even though you can treat the prostate, the bladder is still its own independent organ. It's caused by this degree of obstruction, but just because you treat the prostate, I always like to say, there's no light switch on the bladder that says, okay, there's no more obstruction, now relax, regain your elasticity, be a water.
Separate conditions, pretty much.
Well,
It's
they're
a cause
related.
and effect, but it's two separate conditions, and sometimes the bladder has to be individually treated with medicines. But you can't put somebody on the medicines unless you deal with the obstruction first.
Here's
So
the analogy.
what are the options once you treat the prostate?
The prostate.
Thank you. Once you treat the prostate, what are the options for treating the bladder?
Yeah, so
Just medications?
you have a very good question. So I want to give you a little bit of an analogy. This bladder is a nice, upstanding system. This is Jesse James. This guy shoots first and asks questions later. All right? So this is a problem. This guy makes you run to go to the bathroom, you can't get your pants down, it's coming out. He doesn't ask you your name, he's got the gun on. So you do a TURP on this patient, a lot of times, the bladder calms down. It doesn't have to work as hard. It's not decompensating like it was. That decompensatory mechanism of urgency and frequency, which is the bladder trying to mount this tremendous force to get the urine through the narrow channel, is no longer necessary. And so sometimes, relieving the obstruction solves the bladder dysfunction if we catch it early enough. If you wait too long, it's like your dad used to say to you when you were a little kid, you keep making that face, it's gonna stay that way. So sometimes the receptor changes, and the hormonal changes, and the collagen and the scar tissue have changed so much in the bladder that it'll never be the same. And so after we relieve the obstruction, we then go with a strategy of giving you medicine to calm the bladder down that we couldn't give you beforehand because it would tilt you right into urinary retention. Does that make sense?
Sure.
Okay.
And dietary changes.
Exactly.
There certainly is across the board, whether you have a large prostate, you don't have a large prostate, you just have an overactive bladder. There are common liquids, alcohol, caffeine, green tea, cranberry juice, spicy foods, dark chocolate, lemons, pineapples, oranges, and tomatoes. That's the list. Those
They're all
things they all cause you to run to the bathroom more often than not. Yes. Green tea is probably the worst of all.
Yeah.
You had mentioned, going back to the diagnostic phase, that having a scope or whatever, I think the,
Cystoscopy.
yeah, would be painful. Can you not have anesthesia?
You can, I mean, we always kind of balance risks, right? So it is not really the standard of care to knock you out and put a very small flexible scope into the urethra to look. We have numbing jelly we put in there, it takes literally 2 or 3 minutes. When we knock somebody out, unfortunately, there's a 1 in 10,000 chance we kill you. So we have to kind of keep everything in mind. But yes, we have anesthesiologists who come to our office twice a week. And we can, everything that we can do, we can give you anesthesia, but sometimes it just doesn't make sense to. Right, so we'll, work with you.
I read about a technique that you haven't mentioned, which is in going through the groin to reduce the blood supply to the inner cells of the prostate, and then they die off.
That's
Can you
called,
say something about that?
so that's called prostatic artery embolization. It's really not standard of care. The long-term efficacy is not that great. We use it on men, or we recommend it for men who can't have any of these other procedures, especially because most of these procedures require anesthesia. And so some people are not able to go under anesthesia. They might be too ill, okay, to safely go ahead and do it, either lung issues or heart issues or things like that. So the prostatic artery embolization is more often than not used in those people.
It's kind of a desperation procedure, meaning that when someone is bleeding and they're not a good surgical candidate and you need to stop the bleeding, or we would think about doing something like that, but the efficacy is not so good really for someone who just has quality of life issues or they're in urinary retention. The embolization doesn't really solve those problems so well. You're welcome.
Now, when you determine that there is an enlarged prostate, how do you then find out whether it's cancerous or not?
So, the symptoms of prostate cancer, by the time you have them, you're in trouble. We screen, as Dr. Boschko said, for prostate cancer with the 2 tools that we have. The 2 main tools we have are the digital rectal exam and the PSA. And so those tools are actually very good at helping us find people that are at risk for prostate cancer. When we find someone who's at risk for prostate cancer, we talk about prostate biopsy, or the newer modality is MRI of the prostate. And so that would be our way to diagnose prostate cancer, because by the time you have symptoms for prostate cancer, you're in trouble. And prostate cancer is so common that when you get to a certain age, if you're African American or have a family history, that age is probably 40. If you're not, that age is probably 50 to 55. You want to get screened every year until you look like you're going to keel over. The prostate enlargement is more of talking to you, examining you, maybe checking the urine, maybe doing some of these tests that we talked about, ultrasound, cystoscopy, uroflowmetry, urodynamics. So we kind of screen for the 2 in different ways. But there is an overlap, and it's an interesting thing because a lot of people wonder, well, does the prostate cancer put me at risk for prostate enlargement, or does the prostate enlargement cause prostate cancer? And the quick answer is that they're not related. They both increase with age, but neither one causes the other.
But at a certain age, they don't do the PSA anymore.
Well, so the sort of thinking behind that is that oftentimes it's that 10-year life expectancy. Oftentimes newly diagnosed prostate cancer is going to take 10 years to do you in. So when it looks like you're not going to be around in 10 years, it may not make sense to check the PSA. Now, that's sort of a quick and dirty rule that we have to kind of tailor to each patient, but it's important to not throw the baby out with the bathwater. We save a lot of lives by screening for prostate cancer. And in my opinion, we did people a disservice when the Preventive Services Task Force came out several years ago recommending against prostate cancer screening, along with recommending against breast cancer, colon cancer screening, and recommending against PSA. They subsequently kind of went back and went more in line with the American Cancer Society and the American Urologic Association, which have continued to recommend annual PSA and DRE for people with 10-year life expectancy. So I think reading the newspaper, sometimes you think there's controversy about the PSA. And what I would say is that interesting and controversial data sometimes gets to be the loudest voice in the room. It's not necessarily correct. If you're going to be around 10 years, you should get the blood test. It's just a blood test. And you should get the finger exam by someone who knows what they're doing.
Was the UroLift the latest
urine leptin came out both similar times. They've been around, we adapted it pretty early, it's still only been around for about 3-4 years, depending on the insurance.
Sorry.
So, yeah, you mentioned a list of things that, cause one to need to urinate more often, it should be on the have less often, never list. Are there things in terms of, foods or drinks or lifestyle, exercise, that kind of thing, that can help minimize, slow down, maybe even relieve some of the prostate, restrictive problems?
So, yeah, I mean, there are some supplements that are believed to maybe promote general prostate health, but I'm gonna sort of, put a caveat to that statement, which is, as Dr. Boschko was saying, none of the supplements have been proven in a well-conducted, double-blinded, controlled trial to really be that effective. So things like zinc and selenium and lycopene and pumpkin seeds and vitamin D, there's some pilot studies and poorly performed as far as the methodology studies that show there may be a very modest benefit to these things, but it's not real convincing. And so we prefer to, pursue treatments that have proven efficacy and safety first.
So there aren't any particular foods or drinks, that one would normally have in a be more,
To slow
indicative
down
of
the
cause.
growth.
Are we talking about cancer or enlargement?
Enlargement, either slow down the growth or maybe relieve some of that. The amount that it restricts, is that something that can be affected by diet or exercise? Or is that just sort of an anatomical?
The short answer is no. I mean, I guess the longer answer is eating a healthy diet that's low in fat and red meat, the same things that are healthy for your heart. There's some evidence that helps promote prostate health and maybe even slightly as a secondary risk factor, help a little bit prevent prostate cancer. But the short answer I would say is no, really.
Same with exercise, then it doesn't, increasing blood flow, cardiovascular health, or exercise doesn't affect this.
Eating a healthy diet, maintaining your blood pressure, not having high cholesterol, these things are gonna prevent you from having heart attacks and strokes. There's not something like that with the prostate.
What it does show, our motto is, what's good for the heart is good for the prostate, what's good for the heart is good for the penis. But with the prostate, it's not slowing down growth. So the studies show that generally the people who undergo therapy, if they have prostate cancer and undergo surgery, if they have enlarged prostate and undergo therapy, the recovery seems to go easier for the men who are in better shape.
So, when you talk about before, dark chocolate and green tea and whatever, it is,
The bladder.
that's strictly for reducing the urgency. It doesn't really affect the health of the bladder, it's just.
Correct. They're bladder irritants.
They
Some of their bladder irritants alone, some of their bladder irritants and diuretics, so they make you make more urine. The more urine you make, obviously the more you gotta go to that.
The prostate, other than prostatitis, the enlarged prostate, is that tumors? The benign enlarged prostate, is that tumors or is it just cells growing because we're getting older?
Well, histologically, so when we look at the prostate under the microscope, it occurs in what we call a nodular pattern. So you have these little sort of bumps when you have BPH. We don't really call them tumors, but it's a nodular growth that we see under the microscope where there's more cells, higher numbers of cells. Am I answering your question or is?
Yeah. But it's not inflammation.
Well, BPH is technically not inflammation, it's increased number of cells, mechanical amount of tissue that's getting in the way and blocking that urethra that Dr. Boschko was talking about.
Continues to grow as we go. And also, what medications can we take for allergies, for colds? There's some that block you're urinating altogether.
Yeah, so we prefer the steroids because they don't have the impact that the decongestants do, which work opposite of the alpha blockers. The decongestants are alpha agonists that make the smooth muscle of the prostate and bladder neck contract to make think about the prostate as almost like a pipe underneath your sink, and we can control that aperture by blocking the muscle, which 1/3 of the prostate is muscle, 1/3 is stroma, 1/3 is glands. We can block that muscle contraction and it would sort of dilate up the resistance or the aperture of that pipe by giving alpha blockers. If you give somebody decongestants, it does the opposite. We often see people who take decongestants suddenly being able to, they get a cold, they take decongestants, they end up in the emergency room, they can't pee, and they have to have a catheter put in. Or they take a big dose of Benadryl, which kind of stops the bladder from contracting. Again, they can't pee, they end up in the emergency
So what would you suggest?
Steroids, or we prefer steroids,
Like,
but
what would that
we're
be?
not allergists.
What's an example of that?
So, an inhaled steroid, you can, there's
Like
Inhale.
Flonase or something?
Yeah.
Just curious, how many times you should have an examination? Right now, you don't have any serious problems.
Once a year.
Once a year?
If you have no problem,
And what
you're
numbers
urinating
do you
great
look
once a
for?
year.
What numbers do you look for? Well, the doctor will tell you, but what numbers do you, look at? Cause I had an examination a few months ago.
If you're referring to prostate cancer screening, then it actually is dependent on age and prior values. It's not one absolute number. Like, when you get the lab values in the mail from your internist and you do your screening and it says less than 4 is normal, that's not really the case. That's because the lab can't, delineate and subcategorize all the different factors.
To the side, you can wait.
After all the procedure we talked about, what about the possibility leakage?
So the general statement is that all of the treatments that we talked about, all the procedures are for prostate enlargement. It's very rare to have stress urinary incontinence, where the urine leaks out when you cough or sneeze or laugh. It's very rare to have that as a result of anything that we do for prostate enlargement, even with the aggressive procedures, the TURP and the laser TURP. However, when you get a really big bladder, remember I said this to Jesse James? Jesse James wants to shoot and ask first questions later. When you gotta go, you gotta go. You're running to get to the bathroom, you can't get your pants down, or you put your keys in the door, and suddenly you gotta go, or you hear the breeze, or you hear the silverware, and you gotta go.
No, I'm talking about involuntary leakage.
That's what I'm talking about too. This Jesse James bladder, sometimes we do the surgery to open the prostate up, and it doesn't get better. And so that urgency doesn't get any better, and it actually sometimes can seem a little worse, because this bladder's used to working really hard against an obstructing prostate that we then move out of the way, and so it has to adjust. It doesn't always adjust well. And so that urgency, or what we call urgent incontinence, can sometimes persist after even appropriate treatment for the prostate enlargement, but that's more of a sign of you should have had something done sooner than anything went wrong.
With every new procedure, a surgeon has to do it for the first time and then the next time and the next time. How many times did you have to do this to feel proficient in providing a surgery? And should people who are considering the surgery, should they be asking, how many times have you done this procedure?
Yeah, I mean, we learned this a number of years ago. We've done a lot. The procedures are nice to say that they're very complex. They're not. If you have a lot of experience doing TURP and laser TURPs, like the surgical procedures, those are a lot more involved than these procedures. These procedures are a lot easier to perform, and the manipulation of your hands and what you're doing is similar to some degree. It's just what you're actually doing to the prostate is what's different. But how you approach it, the perspective, how you want to push the tissue to the side or keep the tissue in a certain way is very similar to what you do when you do a laser or a TURP as well. So it doesn't take very long to accomplish, proficiency in these procedures. Nice to say, yeah, it's very complicated. It's actually not.
Yeah, you've spoken about medications for the prostate. What about medications for the bladder to have them relax?
Yeah, so there are medicines that do that. The two main categories are called the anticholinergic antimuscarinics that block the receptor, and this is Jesse James bladder that we talked about that lets the bladder hold more urine and give you more warning before you have to go. Main side effects being dry mouth, sometimes constipation. And the newer medicine is a beta agonist that binds to these beta receptors that kind of does the same thing. But yes, we have an armamentarium for the bladder too that we didn't really kind of get into as much. But sometimes, as Dr. Boschko was saying, these two are very interrelated, and we kind of have to treat both. The bad news is that we don't really have a surgery to fix the bladder when the bladder goes south. We can relieve the obstruction to the prostate, but if we wait too long to treat the prostate, and your bladder becomes a scarred down, flaccid bladder that can't contract, there's no surgery or medicine to fix that. We're stuck. So that's something we are very mindful of.
Are there any new innovations like gene therapy or anything going on in research that's coming down the pipe that you see?
So, within prostate health, there are probably 1,000 studies out there and probably 1,000 startup companies across the world. So there's always something created. Is there anything in the coming of age pipeline in the next year or two? There's a water ablation therapy, which is going to mimic a laser TURP that's using water energy as opposed to laser energy, but it still going to require general anesthesia. It still requires the same amount of time. It still requires the catheter. So far from what we see, I mean, it's still a couple years out and there's no insurance approval of it yet, but it's not really going to give any benefit for what's existing already.
Nothing ready for prime time.
There was an article in the science section of the Times about a month ago about finasteride and Flomax having negative effects on the heart. Can you comment on that?
Well, one of the things that we're more cognizant of is the benefit of testosterone and people that have low testosterone and its relationship to causing something called metabolic syndrome. And one of the things that finasteride can do in some men is by inhibiting the production of dihydrotestosterone. Dr. Boschko alluded to the swelling of the breast, something called gynecomastia, decreased libido. Some people will complain of fatigue. So we're learning a little bit more about that. The Flomax, the main side effect for the Flomax is the orthostatic syncope, meaning that Flomax blocks the same receptors that help you maintain blood supply to your brain when you stand up quickly. And so the Flomax, the people that are already on blood pressure medicines that can do that, kind of sometimes potentiates those side effects so people can get dizzy and fall down and sometimes even hit their head when they're on Flomax, especially if they get up quickly the first week that they're on it. So all of these medicines have side effects, and that's something that we have to think about. And it's often a reason that people want to get off the medicines and do a procedure. But you're right, there's no silver bullet in the sense that some medicines really can cause some problems.
Obviously, the enlarged prostate affects urination, but when the prostate enlarges, does it affect the prostate's functioning?
So the prostate really has a function more in youth, which is it acidifies the sperm as it leaves the male reproductive system and enters the female system. And it just helps with fertility. Outside of that, it is a troublesome organ that either enlarges and causes urinary issues or it turns cancerous.
It's an asset when you're young and it's a liability when you're old. It makes the lion's share of the semen, but once you're done having kids, more trouble than it's worth.
Yes, sir.
How long can you stay on, like Flomax and?
Decades. We have people that have been on it, multiple decades.
But there are also, if you're talking about side effects or if your body gets used to it, your body doesn't get used to the medicine. What happens is your prostate just eventually can outgrow the efficacy of the medicine. And there's only so much muscle relaxation something like Flomax can occur. So if your prostate has a certain amount of obstruction and the muscle gets relaxed and you can urinate better, well, if your prostate gets 50% larger than that and there's that much more congestion, then the muscle relaxation won't accomplish the same thing.
This gentleman's been waiting a long time.
Is there a distinction between your two practices?
So between the two of us, we like to cover all the bases. So we when it comes to prostate cancer, we sort of specialize in different areas. Dr. Boschko has done a robotic fellowship, and so he does robotic prostatectomy, and I offer some cryotherapy and some other things. But with the BPH, we both kind of do the same thing. With the prostate enlargement, we do the same procedures.
So there wouldn't make any distinction between who you would reach out to?
Well, I mean, my personality. No, I think you're going to be happy with your life.
At that higher end of the spectrum of invasive, you're not going to go all the way, so you're at the second from the top. It seemed to me unclear how you would make a decision between the steam and the laser. They both seem to be doing something very similar. They're not maximally invasive.
No, so the laser would be considered surgical. I mean, we actually have a laser that we do under IV sedation. That was actually the video that we showed you. That was done in our office surgical suite. So we set it up with a little bit of sedation, with a colonoscopy style sedation. It does take a while to do. It can take 40 minutes to do. It is surgical in nature because you're physically removing the tissue. You're not cutting into it like a TURP, you're vaporizing the tissue, but you'll have some more bleeding afterwards. There's more of a recovery afterwards, unquestionably. There's a little bit of risk of scar tissue formation. The resume, the steam therapy, is heating up the tissue, but it's not physically removing anything. And then the expectation is over the following 4 weeks, the heat that you applied gets rid of some of the tissue. But that's a 5-minute procedure, done under sedation. It can be done under local, but we like to do it under sedation. It's definitely a step above or below.
So there's something about the steam affecting the tissue that makes, over the coming weeks, makes that tissue kind of slough off and be evacuated.
Correct. It kills off the cells,
And
Exactly.
and then the cells dissolve.
and they just come out
Carbohydrates.
in your
And they
urine.
slough up.
They come out in your urine. then.
Yes, it's not like you actually see the stuff
Right.
coming out, but yeah, it's almost like a iced tea powder.
So is the amount, then I would guess that the amount of tissue removed eventually through the steam process is not as much as the amount of tissue with the laser.
Correct.
Right.
That's what I'm saying, it's a step above. The laser is a step
The
above.
last related question, is there, any greater risk between either of those two procedures in terms of damaging anything else within the prostate or?
So the laser is surgical, so there are risks of something called a bladder neck contraction restriction. Either with turf or a laser turf, you can get scar tissue. I always like to say, if you have a mole in your hand and you laser it or you cut it, you're gonna get a scar. In a certain subgroup of people, you don't always scar properly. Some people get thick scars. If you get a thick scar in your hand, doesn't necessarily translate to scars in the prostate, but that's exactly what can occur, which is the scar never matures. It just grows and grows and grows, and then you have a scar that acts like a blockage. That doesn't happen with the resume, because again, you're not cutting into it, you're not vaporizing, you're not removing actual tissue at the time of. So that's one big difference between.
It's only the laser can cause the scarring.
Right, the resume shouldn't cause
Right,
it.
and if you do get the scar, can you subsequently treat that?
You could, you have to.
Yeah.
Somewhat complicated depending on the degree of the scar, when it presents itself, but it can be treated.
I have a history of prostate cancer in my family. What if you just remove it completely, the prostate?
No.
I just buried my father last year
Yeah.
from prostate cancer.
Well, you're definitely someone that we want to screen
Right.
and make sure we know about it as soon as possible. And we find that prostate cancer when it's organ confined and curable. But unlike the treatment for prostate enlargement, which is relatively minor, remember I said we're giving the prostate a haircut with these treatments. The treatment for prostate cancer has very significant morbidity. And we don't ever want to do a radical prostatectomy where we're taking the entire prostate. Do you want to show them a picture of the prostate? So we're doing a radical, we're removing.
Everything.
I'm gonna get busy.
God.
We're removing this whole gland. And, the rectum is nearby, there's nerves that are important for erections. Somewhere around 3% of people leak urine all the time after a radical prostatectomy. Depending upon what your erections are like, you can expect a 50% chance of being impotent with a radical prostatectomy. You're gonna be sore for 2 months, you got a catheter in your penis for 2 weeks. It's a much bigger deal than what we're talking about. And even with a family history and even being in a high-risk group, because you're an African American, we would not remove your prostate unless you had prostate cancer. And even people who have prostate cancer, as Dr. Bashko alluded to, we are now better able to substratify them. And we didn't talk about this, but there are someone mentioned genomic testing. There's a test called Polaris that really is helping us feel better about not treating low-risk prostate cancer, what's called active surveillance, to avoid the morbidity of impotence